Welcome to The Explainer. Today we're diving into a pathogen that every single one of us in the lab needs to have a healthy respect for, Brucella melitensis. And just so you know, all the info we're covering comes from a detailed monograph we put together using Gemini Deep Search.
Now this quote right here, it really sets the tone, doesn't it? Brucella melitensis is the #1 cause of lab-acquired bacterial infections. We're not just talking about some interesting bug here, we're talking about a serious occupational hazard. This is personal.
All right, so here's our game plan for this briefing. We're going to start with what makes it a high-risk pathogen, then get into the nitty-gritty of why it's so tough to diagnose. We'll look at what the disease actually does to people, cover the different treatment strategies, talk about the headaches of susceptibility testing, and wrap it all up with the most important part, lab safety.
Okay, let's kick things off by defining the enemy. What exactly are we dealing with, and where does it come from?
So at its core, Brucella melitensis is a gram-negative coccobacillus. But the real kicker? It's a facultative intracellular pathogen. That means it's a master of disguise hiding out inside our own cells, which, as you know, makes it a nightmare to get rid of. Its main source is zoonotic. It jumps from sheep and goats to people, usually through things like unpasteurized cheese or just direct contact with infected animals.
Now, if you look at its genes, the whole Brucella genus is super similar. You could almost argue it's all one species. But, and this is a big but, we stick with names like Melitensis for a really important reason. It's an epidemiological breadcrumb. It tells you immediately that the primary host is likely sheep or goats, which is absolutely critical when you're doing a public health investigation.
And that genetic similarity leads us straight into one of the biggest headaches for any clinical lab, actually identifying this thing without putting your staff at risk.
Here it is, the first and maybe the most dangerous trap. Brucella melitensis is this tiny little coccobacillus, and it stains gram-negative so faintly it's like a ghost on the slide. It can really easily hold on to that crystal violet, especially if it's coming out of an automated blood culture system, and trick you into thinking it's a staph species. And that mistake, that's how this pathogen ends up on an open bench. It's a scenario we all dread.
So how do we avoid that trap? What are the alarm bells, the red flags that should make you slam on the brakes and immediately move everything into a BSL-3 environment?
And this is your safety net. This is the profile every sentinel lab needs to have burnt into their brain. You see tiny, faint, gram-negative coccobacilli. It's a slow grower, and it's oxidase positive, catalase positive, and here's the big one, it's rapidly urese positive, like under 2 hours. If you see that combo, you don't ask questions. You treat it as Brucella until a reference lab tells you otherwise. Full stop.
Okay, so we've seen how tricky it is in the lab. Now let's connect that to the patient. What happens when someone actually gets sick with brucellosis?
Well, the classic picture is this really debilitating systemic illness. They call it undulant fever for a reason. The patient's temperature spikes and crashes, usually peaking in the evening. And it comes with these drenching night sweats that have this weirdly specific moldy smell. On top of that, you've got crushing fatigue, terrible muscle and joint pain, and just a total loss of appetite. It's a disease that can just drag on and on if it's not caught. But the systemic stuff is just the beginning. The real, long-term danger comes from focal complications. This bug can set up shop anywhere. Most commonly, you see it in the bones and joints, especially the spine. That's spondylitis. But it can also cause neurobrucellosis. And the most fatal complication, the one that causes most of the deaths, that's Brucella endocarditis, an infection of the heart valves. It's an absolute killer.
So, given how severe this can get, and its nasty habit of hiding in cells, you can bet that treatment isn't a walk in the park. It takes a serious, multi-drug, long-term commitment. Let's look at the different playbooks.
Okay, the big international players, the WHO and the CDC, they have a clear favorite. They recommend Doxycycline combined with an aminoglycoside, like streptomycin or gentamicin. Yeah, it means the patient has to get injections, which isn't ideal, but this combo has the best track record for preventing relapse. And with brucellosis, preventing relapse is everything. The all-oral option with rifampin is easier, sure, but you're running a bigger risk of the infection coming back.
Now, if we look at the Dutch guidelines, they're on a similar page for standard cases. They also love that gentamicin-doxy combo. But here's where they get really specific. And it's a great clinical pearl. For spondylodiscitis, that nasty spinal infection, they don't mess around. They explicitly say to double the course of doxycycline, taking it for a full 12 weeks. That's a huge commitment, but it's what it takes to clear the infection from the bone.
Treating kids is a whole different ballgame. The dividing line is age 8.
If a child is under 8, you absolutely cannot use doxycycline because of the risk of staining their developing teeth. So for the little ones, the go-to regimen is cotrimoxazole plus rifampin for 6 weeks. Once they hit 8 years old, they're generally good to go with the same all-oral regimen as adults.
All right, let's pivot back to the lab for a minute and talk about a really tricky technical subject: antimicrobial susceptibility testing. How do we even know if our drugs are going to work against this thing?
This is one of those slides you might want to screenshot. It's so important. As of right now, EUCAST has not set any SIR breakpoints for Brucella Melitensis. So you cannot, I repeat, cannot report out susceptible or resistant. The only valid way to interpret your results is to take your isolate's MIC and compare it to the published epidemiological cutoff values, the ECOFs. If your MIC is higher than the ECOF, that's your signal for acquired resistance, and that's what you report to the clinician.
And this all brings us right back where we started, to the most critical topic of all: prevention. How do we stop this in the first place, both out in the world and, more importantly for us, inside our own four walls?
3. This number is the law. The second you have even an inkling that you might be looking at a Brucella isolate, all work stops and moves to biosafety level 3. No exceptions, no excuses.
This 5-step protocol should be second nature to us. It's what keeps us safe. Step 1, suspect it, based on that biochemical profile we talked about. Step 2, stop everything you're doing on the open bench immediately. Step 3, secure those plates. Tape them shut, label them clearly. Step 4, contain. All future work happens in a certified Class 2 biosafety cabinet. And Step 5, refer. Box it up and send it to a reference lab that can give you a definitive ID.
Now, what if the worst happens? What if there's a high-risk exposure, a dropped plate, a centrifuge mishap? Well, there's a plan for that too. It's called post-exposure prophylaxis, or PEP. The standard regimen is a 21-day course of doxycycline and rifampin, but it doesn't stop there. It also involves careful serological monitoring for 24 weeks to make sure the infection doesn't take hold.
So, that brings us to a final thought, something to really chew on. Unlike so many of the bugs we fight, Brucella has a pretty stable genome. It's not a master of picking up new resistance genes. So, is its greatest threat really some future superbug version? Or is the biggest danger, right here and now, simply our own failure to recognize it when it's sitting on our bench?
Hey, if you want to dig into the primary sources for all this, you can find them in the notebook document linked below. And if you found this briefing useful, please subscribe for more explainers on these high-stakes pathogens. We'd also love to hear from you. Your experience is valuable, so drop a comment, especially about your lab's safety protocols. Thanks so much for watching.